Thank you. Thank you so much for the kind introduction. And first of all, a very good evening to all of you. And at the outset, I must thank Dr. Banshi Sabu and Dr. Vasanta Kumara sir and the whole scientific committee for giving me this opportunity to share my views on this prestigious platform. And I must congratulate the whole scientific committee and organizing committee for wonderfully organizing this conference. The topic which has been assigned to me is really of great clinical importance, and I hope I can do justice with the topic. And the topic is hyperglycemia management in transplant patients and patients on steroid. Just hold on, please. The slides are not moving. Just give me a minute. Yeah. We all know that solid organ transplant is the best option which available as of now for organ failure, including all kind of organs like heart, kidney, pancreas, lungs, and even in some cases the small bowel transplant also. But there are really issues of post-transplant diabetes mellitus, which is a frequent consequence of all solid organ transplantation. And it is really associated with greater mortality and increased chances of infection in these kind of subgroups of patients. We know that with the newer emerging free immunosuppression regimes, it was expected that probably they can reduce the risk of developing diabetes significantly. But unfortunately, the fact is that even without a steroid, risk of diabetes remains a major concern. And the data till date available, although is mainly from kidney transplant patients, and the incidence is really high in these kind of patients, but we have seen that PTDM is more common among liver transplant rather than kidney transplant patients. So now coming to whether the PTDM is another form of type 2 diabetes mellitus or it is a separate pathophysiological entity. In 2003 consensus, it was named as NODAT, that is new-onset diabetes mellitus in transplant patient. But after 2013 consensus, the first recommendation was to change the term from NODAT to PTDM because many of the patients might be having diabetes in the pre-transplant period also, which gone undetected, or they may be destined to develop diabetes irrespective of transplantation. And it is also really unclear whether the thresholds we are using for general population can be used to diagnose PTDM in post-transplant patients also. The data till date available with the available evidences says that the major concern is not of microvascular diseases associated with these patients, but rather the increased risk of cardiovascular disease and death also. There is a study showing from Oslo Transplant Center that the persistently high fasting plasma glucose of more than or equal to 126 milligram per deciliter and OGT-derived hyperglycemia of more than 200 milligram per deciliter as well as more than 140 milligram per deciliter were all associated with mortality in kidney transplant patients, while HbA1c levels of more than 6.5% were not associated with mortality. This cartoon is showing the evolution, how the post-transplant diabetes evolved in these post-transplant patients because of the moderate to severe damage to beta cells, pancreatic beta cells. It may be pre-diabetes or it may be present as frank diabetes also. The incidence, according to the data available till date, is of 10 to 74% in kidney transplant patient, 11 to 38% in heart transplant patient, and in liver transplant patient, the incidence ranges from 7 to 30%, while 32% in lung transplant patient. Now, coming to what are the key risk factors which are responsible or which may be responsible for post-transplant diabetes mellitus. There may be some pre-existing diabetes risk factor in the patients who are awaiting for transplant, like age more than 40 years or BMI more than 25 kg per meter squares, or increased waist circumference is also an independent risk factor which can lead to post-transplant diabetes mellitus. Race and ethnicity is also responsible, may also be responsible for the same, where diabetes mellitus candidate gene may also be associated, certain conditions, metabolic syndromes, pre-diabetes, particularly low level of HDL may be associated with post-transplant diabetes mellitus. We know that post-transplant conditions are the inflammatory conditions, and there may be some acute or chronic inflammation existing in these patients, which can lead to PTDM, and certain inflammations like hepatitis C, cytomegalovirus, or HLA mismatch can also lead to post-transplant diabetes mellitus. Like some other factors like PCKD in kidney, CF in lung treatment, even statins are also suspected to, low vitamin D levels, low magnesium levels are also suspected to be a cause of post-transplant diabetes mellitus. For immunosuppressants, we definitely know they can lead to hyperglycemic conditions in these patients, and corticosteroids, they are well established to cause hyperglycemia through a number of mechanisms, maybe either by worsening pre-existing insulin resistance or by increasing hepatic gluconeogenesis, and in long term by stimulating appetite and weight gain also. Where high-dose corticosteroids, which are oftenly used in the initial post-transplant period, have a greater impact than the chronic low-dose corticosteroids, which are being used as a maintenance therapy and immunosuppression protocols in these patients. There are increasing evidence which says that the use of immunosuppressants, particularly CNIs, tacrolimus, and cyclosporins, and inhibitors of mammalian target of rapamycin, sirolimus, rapamycin, and everolimus, they also may contribute to PTDM. While the animal studies suggest that these effects of tacrolimus and sirolimus on glucose metabolism are mainly dose dependent. Now, coming to the timeline, when can we detect, or when we should detect or term the patient as post-transplant diabetes mellitus? In the pre-transplant phase also, certain patients, few group of patients might be having risk factors like age, race, ethnicity, or maybe having metabolic syndrome, whether it is obesity, pre-diabetes, hyperlipidemia, insulin resistance, or with the family history of diabetes mellitus or genetics. They might play a role in the precipitation of post-transplant diabetes mellitus in the later phase, that is after 12 to 24 months. And the initial 3 to 12 weeks, tacrolimus, steroid use, cyclosporin, rapamycin, everolimus, they may cause, in most of the cases, hyperglycemia in the initial post-transplant phase. Now, according to 2021 guidelines from the Association of British Clinical Diabetologists and Renal Association, every patient who is going to transplant should be assessed for the risk of development of diabetes according to 1B evidence, and all people who are awaiting for transplantation, they should be educated for the risk of developing diabetes mellitus, as well as they should be encouraged to minimize the weight gain also. And if the patient is having any risk factor like hepatitis C or any other risk factor, they should be treated while they are waiting for the transplantation. We know that immunosuppression drugs, they can impact insulin signaling and they can cause post-transplant diabetes mellitus. Where corticosteroids, tacrolimus, they have increased risk of diabetes mellitus in these patients, while cyclosporin, M2RI, basiliximab, they have increased risk but in comparison to corticosteroid and lacrolimus, they have lower risk. Where belastacet is, as per the evidence is available, they have slightly decreased risk of developing post-transplant diabetes mellitus, while mycophenolate and azathioprine, they have no effect on such development of diabetes mellitus. Now, the recommendations also says that if anyone is going to modify the immunosuppression regime to attenuate PTDM risk, it should always be balanced against risk for allograft rejection, and individualization of immunosuppression should be done on the recipient's immunologic and glycemic risk, which should be taken as a part of an overall strategy. The drug should be chosen primarily to prevent rejection rather than PTDM, and there are as such no evidences which suggest that there is a role of changing immunosuppressive therapy in the management of PTDM, and there are no such evidences that newer agents such as belatacept are beneficial in controlling PTDM in these patients with class 1C recommendation. So coming to how to diagnose these patients, or when can we say that these patients are having post-transplant diabetes mellitus. For every pre-transplant patient should be screened for diabetes by doing FPG and A1C, and other cardiovascular risk factors like lipid profile and blood pressure should also be assessed. And if there are any risk factors for type 2 diabetes, they should be managed appropriately in this period of time. In post-op patients, post-lung CBG monitoring are advisable, and to confirm the diagnosis, OGTT is the gold standard test, where A1C is not reliable in the immediate post-op patients. After 3 months, A1C can be done, and OGTT is a better treatment, better diagnostic modality in these patients. After 12 months, then annually, the patient should be assessed for A1C, and OGTT may also be done in these patients. The recommendation says that in immediate first 6 weeks post-operative period, we should avoid to diagnose PTDM, because transient hyperglycemia is almost always associated in this period of time with class 1B recommendation, and to detect post-operative hyperglycemia, afternoon capillary blood glucose monitoring should be done, and formal testing of these patients can be done once the patient is clinically stable, and it can be made after 6 weeks of post-transplantation by using OGTT test. OGTT is definitely a current gold standard for diagnosis of PTDM. It may not be practical in some use, but it can be utilized whenever and wherever it is possible for additional risk stratification and for diagnostic confirmation. Where HbA1c of equal to or more than 6.5% is not a very reliable test, and it can only be done in clinically stable recipients after first 3 months of post-transplantation. And in asymptomatic patient, the test should be repeated after 2 weeks to confirm the diagnosis. The caution should always be taken while using HbA1c. If there is a presence of factors that may impair accurate interpretation that by class 1A recommendation. In stable patient, always FPG and HbA1c both should be combined to detect the majority of PTDM patient, and the patients who are awaiting for transplant should be screened annually by testing FPG and HbA1c, where high-risk patients should then go for OGTT testing. The use of novel diagnostic tests such as fructosamine and glycated albumin are undetermined, and they are not recommended as clinical tools for diagnosing these patients. Now, coming to the most important part, that is the management part of the post-transplant diabetes mellitus. And we know that healthy behavior interventions, lifestyle modification always play a role in managing hyperglycemia in any kind of patient. We should always individualize glycemic targets in these patients. And if in any case pharmacotherapy is required, the drugs which should be preferred which do not cause any kind of weight gain. Sulfonylureas are especially avoided in transplant patient, in pancreas transplant and renal transplant patient. And insulin is recommended if there are osmotic symptoms or there is severe hyperglycemia. This is the treatment or management algorithm which is given as 2021 guidelines from Association of British Clinical Diabetologists and Renal Association. These patients, if in the immediate post-transplant period, if they have glucose level of 14 millimole, less than 14 millimole per liter, the oral hypoglycemic therapy or agents can be chosen for the treatment. And if the glucose level is more than 14 millimole per liter, insulin is the drug of choice for these patients. And in the clinically stable period, that is after 6 weeks, non-insulin therapy can be chosen as a first line of treatment. And even if this patient is above the glycemic target, we can add any other non-insulin therapy. And if still the glycemic targets are not achieved, insulin is the indicated in these kind of patients. And among oral hypoglycemic agents, metformin can be used if the BMI is more than or equal to 25 and EGFR is more than 30. And for the patients of BMI more than 25 and EGFR is more than 15, GLP-1 receptor agonist can be chosen. And if we want to give or prescribe SGLT2 inhibitors, the expert advice should be there for these kind of patients, where pioglitazone should be used with little caution. DPP4 inhibitors don't have any safety concerns in these kind of patients. Sulfonylureas and meglitide, they should be used with caution in these patients. Now, coming to the in-hospital management of these patients, there are so many things which can, so many factors which can impact glycemic control and influence the risk for adverse effect. So these should be considered while treating these patients. And there are no specific glycemic targets which are being established for immediate post-transplant patients, while there are studies showing that in kidney transplant patient, tight glycemic control between 70 to 110 milligram per deciliter is associated with increased hypoglycemia and may increase the risk for future rejection. And we should follow the standard blood glucose control protocol, that is maintaining blood glucose between 70 to 180 milligram per deciliter. Or we can follow the current general practice guidelines for inpatient blood glucose goals, that is 140 to 180 milligram per deciliter. In non-intensive care unit, pre-meal blood glucose goal should be targeted below 140 and random blood glucose goal should be below 180 milligram per deciliter. In immediate post-transplant patient, there are concerns of high dose immunosuppression. There may be pain associated and stress is very high in this period. And the patient is usually kept under observation in intensive care unit, where these patients require IV insulin infusion protocol. And these patients should be monitored very diligently. Early blood glucose monitoring should be done, and they may require frequent dose adjustment of insulin infusions in the immediate post-op period because of anticipated dose changes to cover corticosteroid because of corticosteroid high doses in this period. In the first week post-transplant patients, nutritional intake increases, steroid dose is to be weaned off, and there is rapid improvement in renal function. So high dose immunosuppression is really common in this period So the patient should be switched to, can be or should be switched to subcutaneous insulin. And once the patient is stable and starting oral intake, the total dose should be calculated from last 8 to 24 hours IV insulin requirement, and patient should be monitored at least 4 times daily in first post-op period of transplantation. And insulin requirement, we should take into consideration that insulin requirement may change daily due to improving renal function and increased nutritional intake also by day-to-day basis. In acute steroid boluses, when we have to give, there may be increased requirement of insulin, and at this time we can consider long-acting insulins in NPH, glargine, or detamir for steroid boluses, or if very high dose steroids are being given in these patients, temporary IV insulin infusion can be started. There may be some fluctuations in renal functions, particularly after kidney transplant. So this should be considered, and we can transition back to the previous insulin regime once the steroids are tapered off, or in high dose steroid boluses regime is complete. And if the blood glucose is still rising significantly, IV insulin infusion can be considered as a temporary therapy in these patients. And once the patient is requiring TPN or enteral feeding, the insulin requirements can be increased. So at this period of time, IV insulin infusion should be considered, or we can divide some insulin requirement for TPN back also. And once the IV requirement are established and the patient is stable, we can switch over to NPH long-acting insulin every 8 hours, plus boluses for correction every 4 to 6 hours. We should consider that insulin dose adjustment can be required in this period if the patient is off TPN or not taking meals or not accepting meals properly. And long-acting insulin should be decreased if the TPN or tube feeds are stopped in these patients. Once the patient are stable, IV insulin can be transitioned, that we know, to long-acting insulin with the correction boluses every 4 to 6 hours. And it is really essential to anticipate the change the insulin therapy, whether it is IV insulin or subcutaneous insulin, with noted interval improvement in insulin resistance, planned transition of TPN, or planned taper off of immunosuppression regime. To summarize the treatment in hospital patients, insulin requirements for hospitalized transplant recipients can vary considerably depending upon the clinical scenario, and it really requires diligent blood glucose monitoring and frequent insulin dose adjustment or titration can really be required in these patients. In general, as an inpatient management of diabetes in non-transplant patient, oral hypoglycemic medications should be avoided because of risk of side effects and because of some concerns over a lack of efficacy in this kind of setting. Even in the event that a transplant patient require very low dose insulin therapy, there are considerations which should be made to initiate oral hypoglycemic therapy at the time of discharge or at the follow-up clinic visit. This is the table summarizing the use of all oral hypoglycemic, how can we use, and which oral hypoglycemic can be used in such kind of scenario. There are evidences from 2 studies available with SGLT2 inhibitors in this kind of setting in PTDM patients. And this is the table which shows that there are some direct and indirect effect on the organs of both the drugs, that is SGLT2 inhibitors and GLP-1 receptor agonist. I'll not go into detail, but both of these agents can be used with little expertise in these kind of patients. According to British Clinical Diabetologist and Renal Association guidelines, in immediately post-transplant patient, and early postoperative hyperglycemia should be actively monitored and treated. And if it is mild, then oral hypoglycemic agents can be considered. Otherwise, early insulin therapy always be instituted, either IV or subcutaneous, where glycemic target should be around 7%, but it can be adjusted according to degree of CKD, age, comorbidity, or ability to self-manage and patient preference also. All the patients who are having confirmed diagnosis of patient PTDM, they should be offered structured diabetes education, which is really very necessary in this patient. And these patients should be, and this diagnosis, this education should be conveyed to primary care practitioners also, and they should also be offered for structured care and regular screening for any kind of complication. This has also been suggested that patients with stable EGFR of more than 30 ml per minute and a BMI of more than 25 kg per meter square, metformin can be considered as a first-line oral therapy, while other therapies like sulfonylureas, meglitinide, DPP4 inhibitors, triaglitazones, GLP-1 analogs, sulfonylureas should be used with care, and doses should be adjusted according to EGFR. SGLT2 definitely should be used with caution in patients with a stable EGFR of more than 30 ml, and in patients where there are lower risk of UTI with the expertise, it should be used. And insulin therapy should be considered in every patient who have inadequate glucose control or who have symptomatic hypoglycemia also. Blood pressure should be monitored or should be maintained below 130 by 80 millimeter of mercury, and all patients should be offered statin therapy irrespective of cholesterol levels in those patients. And all the patients should have an access to specialist diabetes expertise within a multidisciplinary team setting with a class 1C recommendation. For non-renal transplant setting, organ-specific factors should be considered while counseling patients for their risk of PTDM before going for solid organ transplantation, and diagnosis of PTDM should be consistent across different solid organ transplant setting with organ-specific caveats in mind. The management should be consistent across different solid organ transplant setting and organ-specific caveats in mind with class 1B recommendation. Now, here are few studies done with these kind of patients, and this is a study done, a Spanish multicenter cross-sectional study. The objective of this study was to estimate the prevalence of and access the risk factor for PTDM, where 2,178 patients were included. And it was found that 17 and 4/10% of the patients who did not have diabetes mellitus prior to transplantation, they developed PTDM. And the greater prevalence was observed among patients with a family history, HCV, and tacrolimus patients. So the learnings are there that the prevalence of PTDM among kidney recipients was higher than that in general population, and especially in those patients with a family history and HCV positive, and tacrolimus is an associated risk factor in this patient. There was another study which was conducted with an objective to evaluate the association between admission, blood glucose, and mortality following hospitalization of organ transplant. And this study included 832 patients with the conclusion that in organ transplant recipient who are admitted for any cause to a general ward, markedly elevated ABG in these patients without diabetes was found to be independently associated with higher mortality risk in comparison with abnormal ABG levels. And in patients who were having diabetes, there was no such association between ABG level and mortality. while there is increased mortality risk was independent of age, gender, smoking, alcohol, or any other comorbidity. This is the Kaplan-Meier curve, which is depicting better survival in patients without diabetes with normal ABG levels in comparison to those with markedly elevated ABG, and the patients in diabetes, there was no significant difference in survival across the various ABG categories. There was another study done for evaluating the recurrent incidence of hyperglycemia, which are going to affect differently by immunosuppressive regimes, demographic and medical related risk factors, and inpatient hyperglycemic conditions. So this was a retrospective analysis and conducted in 407 patients undergoing transplant. So the conclusion of this study draws attention to the importance of analyzing the risk factors associated with the disease with respect to both its first and recurrent incidence, as well as carefully differentiating these two perspectives. And this is a fact that is currently overlooked in the literature available. So conclusions are there that diabetogenic effect of tacrolimus can be established when hyperglycemia is experienced for the first time. However, contrary to this effect cannot be established for the recurrent incidence of hyperglycemia. As the diabetogenic effect is ruled out, the results show that age, race, BMI, HDL, steroid use, and uric acid are the only significant risk factor for the recurrent incidence. So this was the study done to show the influence of lifestyle modification in renal transplant recipients with postprandial hyperglycemia, and it concluded that glucose metabolism can deteriorate in transplant recipient despite passive lifestyle modification advice. And this is also showing that active lifestyle modification benefits high-risk transplant recipient with glucose intolerance and should be aggressively pursued in these patients. Another study was done. It was a national survey from China Liver Transplant Registry. It was aimed to evaluate the etiology and prognosis of NOH within 1 month after liver transplant, and it included 3,339 adult patients, showing that NOH lead to increased morbidity and mortality in liver recipients. There was a close surveillance and tight control of blood glucose, which is desired in immediate post-op period following liver transplant, particularly in those patients with delayed graft function and receiving corticosteroid. So strategic targeting graft ischemic injury may help maintain glucose homeostasis in these patients. So as a take-home message, we are witnessing that efforts are being made to prevent diabetes and to improve immunosuppressive regimes which can contribute to PTDM. But it's really important that the immunosuppression regime should be chosen which is most likely to be effective for successful solid organ transplant and not to minimize the risk of PTDM. Long-term outcomes for the patients are linked first and foremost to the graft survival, and the management in these type of patient is more challenging in comparison to non-transplant setting, because they have a higher risk of fluctuating kidney function. There are varying type of nutritional supplementation that impact diabetes treatment regimes also, and there are large variations in insulin resistance due to changes in immunosuppression, intermittent episodes of rejection, infection, or the need for interval procedure for surgery. And until PTDM, it can be reliably prevented. It will require management much like those with pre-transplant diabetes, and management is further complicated by the greater risk for drug-drug interaction between the immunosuppression agents and the drugs needed to manage other comorbidities like hypertension and hyperlipidemia. But it is really a good news that despite these challenges, the management of the patients with PTDM has greatly improved over the period, and there is also hope for further improvement as more groups are working on better strategies to prevent as well as to treat PTDM for the benefit of all future transplant recipients. These are the differences. With this, I end my talk, and thank you so much for patient listening and for being there and for sparing your valuable time. Thank you so much.